Well, good afternoon, folks. I don't see enough coffee cups out there. It's a difficult time of day, but thank you for joining us today. It's my pleasure to welcome you here. My name is Neil Saunders. I'm with Mindray, North America. Along with our esteemed colleagues from Medtronic, we have the pleasure of presenting this topic for you this afternoon. Our guest speaker, you probably don't need introduction to. Many of you know him, I'm sure. But Dr. Khanna has agreed to talk with us today. You can see his list of titles up on the opening slide, but he's Assistant Professor of Anesthesiology and Vice Chair of Research within the Department of Anesthesiology, Section of Critical Care at the Wake Forest University School of Medicine in Winston-Salem. Also a member of the Wake Center for Biomedical Informatics, the Center for Healthcare Innovation, and the Wake Forest Hypertension and Vascular Research Cardiovascular Science Center. It's certainly a mouthful, but on that note, I'd like Dr. Khanna to welcome you to the podium and discuss. Thank you.
Okay. All right. Well, I like to walk around, so I'm going to walk around. Thank you for that nice introduction, and like my good friend said here, I hope there's enough caffeine in your systems. I'm trying to stay awake after what already seems a long day, but I hope you guys are going to stay awake through all of this. We're going to talk about near-infrared spectroscopy for ECMO and CVICU patients. I'm going to touch on both cardiac surgery and ECMO, focus more on ECMO, especially the somatic applications of near-infrared spectroscopy. I hope we'll have time for a nice discussion afterwards and sort of to look at where we are and what we need to do to sort of build evidence in this area. These are some of my affiliations that have already been highlighted, and these are relevant disclosures. So learning objectives, lots of words on this slide, but essentially we're going to talk about some of the challenges. Why do we need something like near-infrared spectroscopy in a sense to maintain a balance between systemic hemodynamics to ensure cerebral oxygen supply demand, specifically both post-operatively and in ECMO patients. And then we'll discuss some NIRS technology, what the value itself means and how to interpret it, and some relevant clinical applications. So let me just start with the average cardiac surgical patient, and I put in parentheses ECMO, and I say that because we're looking at essentially a similar patient population in most situations. So what is very obvious is that it's usually a sick patient population, that demographic of the older patient with a multitude of comorbidities and with all sorts of risk factors for organ system failure in the ICU and beyond ICU stay. Some of these are modifiable, but a lot of them are non-modifiable issues, and that's why what we do to them and how we monitor them in the intensive care unit becomes a really important issue. The one area I'm going to focus on is cerebrovascular events. So both after cardiac surgery and in the ECMO population, cerebrovascular events are an important downstream complication that we try and avoid. But unfortunately, again, this is a population that's at high risk for cerebrovascular events. Here we have a quoted risk of up to an incidence of 6% in cardiac surgical patients. And yes, we do know that a stroke after cardiac surgery is important. It increases ICU length of stay, it increases morbidity, and does lead to mortality as well. Now, what are the challenges of monitoring a post-cardiac surgical patient? And I'm going to sort of flip to an ECMO patient as well. Sort of, some common sense issues, right? There's at least initially intubated, sedated, so it's difficult to perform a clean and thorough neurological exam. Hemodynamic instability is common in the cardiac surgical population, and overall risk of postoperative complications and organ system failure is fairly high. The ECMO patient is another sort of layer of complexity where, in addition to being sedated, intubated, where we cannot perform a neurological exam, as I'm going to tell you in the slides to follow, we mostly are focused on measures of global perfusion and oxygenation, and that may not be enough, specifically when we are looking at the brain. And then, most importantly, there are some specific complications in ECMO patients like north-south syndrome and downstream limb ischemia that are really critical and are common, more common than we would think they should be, and are certainly avoidable in a lot of situations. So talking about monitoring, what are the routine measurements in an average CVICU, right? So we do all of this most of the time, or all of the time. We have an invasive arterial line, we have a PA catheter, or at least a central line where we're trying to do a central venous or mixed venous oxygen saturation. If we have PA catheters, then giving us right-sided hemodynamics, and it's also giving us PA pressures. We obviously have our pulse ox, and then we have the opportunity to use things like TEE or point-of-care ultrasound to look at the heart. Now, the one thing you will see when I talk about all of these routine measurements, they are measurements of global oxygenation, perfusion, or global hemodynamics, right? None of these will specifically focus on local oxygen perfusion or tissue level oxygen perfusion or individual tissue hemodynamics. I'll talk why that becomes critical. So as we try and answer questions around cerebral oximetry, these are the things that we and a lot of us who practice in the cardiac surgical environment want to know. We want to know, well, is hypotension common after cardiac surgery? And if it is common, is it related to cerebral desaturation? Is cerebral desaturation a thing after cardiac surgery? And then again, same question in the ECMO patient, what's the impact of cerebral desaturation? And then how do these cerebral NIRS value influence my care? How can I alter my care? So let me start with the concept of regional oxygenation. I talked about, SpO2. We measure SpO2 all the time, so why not just stick to SpO2? Well, several reasons, but most important that we know that the delivery of oxygen, or DO2, is not entirely same to each organ system. There is autoregulation, and then there is anatomical issues such as local ischemia that become very, very relevant. And because of that, and because each organ might have its own unique oxygen consumption requirements, we do need to focus at organ level oxygenation if we really want to see how our organs are doing in terms of the VO2 DO2 balance. I'll talk a little bit about the north-south syndrome in the slides to follow, but yes, near-infrared spectroscopy does get us closer to monitoring oxygenation at a regional level instead of a global level. You all know this. I don't need to introduce this. This is taught to us very early during our training. There is a balance between oxygen delivery and consumption, delivery being the cardiac output, hemoglobin, and arterial oxygenation, and oxygen consumption being things like fever, sepsis, anxiety, pain, muscle activity, and so on and so forth. All of our patients, all of our critically ill patients are uniquely different, but are also, what we are trying to do every day in the intensive care unit is to maintain this oxygen consumption delivery balance. And by doing that, we're trying to preserve organ system function. Now, this is a really nice review article written by Daniel DeBacker and Jean-Louis Vincent, and I really like this diagram here because it describes the physiological state, and then it tells us how most of our shock states in the ICU, our patients are never in physiological equilibrium. So when we look at the concept of oxygen delivery and oxygen consumption, there is a straight line where and then there's a flat part of this relationship. We want our patients to mostly be here where oxygen consumption becomes independent of oxygen delivery. However, a lot of our patients are still on here, on the upward, on this slope right here. We don't know exactly where they are. And then some specifically with a more pro-inflammatory state. So say you're a patient with post-cardiopulmonary bypass vasoplegia with pure distributive shock. This whole curve then, or this whole relationship shifts to the right. Well, they're still on the incline of this curve. They're still not on the flat part, and we want everyone here to be on the flat part. Bottom line being, shock is common in the ICU. Shock comes in mixed flavors, but almost none of our ICU patients are in a stable situation as far as their oxygen supply-demand balance is concerned. The other issue is, and something that I'm personally very passionate about, is hypotension in the intensive care unit. It is really, really common, and despite our best efforts and knowing the guidelines and knowing blood pressure targets for what they're worth, we're unable to entirely, do a great job in terms of keeping our patients' maps at a point that we can avoid organ system failure. I go back here for a second. This is a retrospective database where we looked at different blood pressure thresholds, and we looked at organ system failure and mortality as an outcome. And it's no surprise we found an association where the map dropped to about 65 or lower, that organ system failure and mortality increased. There's about 50 publications like that out there, especially in the last 10 years or so. We know that critically ill patients are hypotensive. They're frequently hypotensive. We also know that hypotension, despite our best efforts, we try to get to that map of 65 or beyond. We're unable to do that. When we're not able to do that, our patients suffer in terms of organ system failure and mortality. Now, the other and more important part of this blood pressure discussion is what happens at the tissue levels in terms of microcirculation. And I know that macro and microcirculation is a discussion topic for a whole another day. I can spend a full day talking about it, but I want to show and share these with you, and I've got my fellows in the audience, and they've probably seen this because I show this to them when I talk back home. But a healthy microcirculation and a microcirculation in a patient on 3 vasopressors. Both patients are at a map of 65 or beyond. And I'll try and play these clips for you if I can. Okay, here we go. So what you can see, this is sublingual microcirculation, healthy sublingual microcirculation, lots of good capillary flow and lots of brisk capillary flow. But on the other side, you see a patient on 3 vasopressors. MAP is still 65, but you see how the microcapillary drop out here, and you see how sluggish the flow is. These were real patients that I have personally done these microcirculation studies, and we've seen these differences, obvious differences. What I'm trying to tell you is that we can keep a map, but we cannot ensure good microcirculatory flow, and that whole argument of macro versus microcirculation does continue. But we have to focus on not just MAP, but other hemodynamic targets that will allow us to achieve good flow. Now, the other issue is our patients that come into the intensive care unit are usually carrying chronic hypertension, and chronic hypertension will do this to the cerebral autoregulation curve. So the cerebral blood flow versus MAP, again, we know that cerebral blood flow and MAP, we want to be here in the autoregulatory state, that we want to be between a MAP of say about 50 to 150, where the blood flow is stable and independent of MAP. Patients who are chronic hypertensives, this shifts all the way to the right. We have no good means of knowing how much to the right this has shifted. We will often be at a MAP of 65. We feel that cerebral blood flow is stable and we're in a good place. However, our patient has been carrying hypertension for 30 years, this map of 65 may no longer generate adequate cerebral blood flow for our patients. Now, yes, there is clinical gestalt into, oh, my patient had a map of 85 before he or she came to the ICU. I'm going to try and keep my map 85 there, but there is, as we all know, it is not easy keeping high maps in the ICU. That is also a separate issue. This is where the concept of understanding hypotension, macrohemodynamics, cerebral blood flow, and cerebral desaturation all comes together. Finally, I also want to talk a little bit about the problem of covert strokes. So there is obviously the clinically manifested overt strokes where we see the clinical manifestations, we try to do what we can for our patients. But the Neurovision trial, both done with non-cardiac surgery and cardiac surgery, and specifically I'll touch on cardiac surgery, it's shown that small trial so far, 50 patients in cardiac surgery, about 40% of them had covert strokes detected on MRI. These covert strokes have downstream implications in terms of neurocognitive recovery and outcomes for these patients. So while your patient still might wake up okay and get extubated, these strokes will affect quality of life afterwards. There is still ongoing work on the Neurovision trial, and we'll definitely talk more as we get more results. So how does all of this fit into NIRS? Well, NIRS itself is measuring organ-specific oxygen extraction and utilization. It's providing a non-invasive monitoring, both cerebral and somatic, and I'll talk a little bit more about somatic as well. We're just doing a difference between the arterial contribution and the venous contribution. We are looking at vascular beds, both at the cerebral level and the somatic level, and we're assessing organs individually to see this balance between arterial venous combination, arterial venous oxygen delivery and extraction. And importantly, we're getting a real-time measure to alert you and I on a oxygen deficit that will allow us earlier interventions and hopefully organ salvage. This is how the NIRS technology works. There's two detectors, a shallow and a deep detector, and we have the two pathways essentially cross the venous bed, and we subtract values across the two pathways to get a real-time oxygen reserve capacity in the specific tissue under investigation. I really want to spend some time on this because then once people put NIRS on their patients, they think about the values, and there is a whole lot of confusion on what to do when the NIRS values change. And this is a great reference if you have time. These papers came out about 10 years ago from a group in Europe, but I still use them for teaching myself and for teaching you all. The most important thing to understand is the value of cerebral oxygenation, or RSO2. We usually, I'll talk about what is a normal value, but we talk about a delta of 20%. That 20% should probably not be from a normal value, but should be from what is normal for your patient. So you should know your patient's baseline RSO2 before you look at the delta. Then look at your patient and see whether it's a one-sided cerebral desaturation versus a bilateral event. The issues are essentially different. Anytime we're looking at a one-sided problem, you should firstly identify physical impediments to cerebral blood flow, that is the position of your cannulas and catheters that would, and the patient's head position that would kink one of these or impede cerebral blood flow, and try and do a common sense intervention to fix that. Any other one-sided unilateral reduction of more than 20% then needs to be investigated in terms of other significant catastrophic complications, and I'll get to those in a separate slide. If it is a bilateral reduction in NIRS values, Bilateral reductions usually signify a systemic issue. And that is why you go down that thought process of oxygen supply and demand or consumption. So you will look at hemodynamics. Does the patient have a good blood pressure? What is the systemic saturation? The systemic saturation is low. Then obviously cerebral saturation is bilaterally low. What are we doing with ventilation? If the PaCO2 is high or too low, then again you need to have a state of eucapnia. If you don't have the trucks, the RBCs to carry the oxygen, that's a problem, need to fix that. And then you need to look at the pump function, optimize pump function and cardiac function. And finally need to look at things that would increase oxygen demand at the level of the brain. That would be things like probably there's a seizure or fever or cerebral edema that is also impeding cerebral oxygenation. So bilateral issues, usually systemic issues, unilateral issues, look at physical malpositions and things that you can quickly fix. I'll come back to the catastrophic events associated with unilateral issues, but this is a really good stepwise approach that I think all of us should use in our ICUs when we look at NIRS. Now, there's tons and tons of available devices. I'm not going into available devices. There is the bottom line I'd like to say about available devices is that I am a person who likes to see minimal monitors by the patient's bedside in the ICU. Less monitors, more data on a single monitor. That is my mantra, not just with NIRS, but with all hemodynamics and all other investigations that I do in the ICU. I feel in a world where we walk into a patient's ICU room and we're so distracted on the multiple things that are surrounding the patient, we often don't get to focus on the patient, all the data that's coming in a single visualizable manner. So for me, anything that allows me to do that, like a single focus, less monitors, and more data, I'd love to sort of build my practice that way. Now, people often ask me, what is a normal NIRS value? So normal NIRS values in general, around 70 plus minus 5%. These have been validated against internal jugular, mixed venous oxygenation, cerebral mixed venous oxygenation values, and they're about the same. Now, also remember, we need to get baselines on every patient, preferably every patient, because there is a variance to this normal value as well. But as a general rule, I would say 65 to 70 is probably a good start. Now, we won't have the time today to go over every study, but yes, in the last 20 years or so, there's been data, retrospective data, propensity matched data, and also small pilot randomized trials that have shown the benefit of cerebral oxygenation monitoring in terms of organ system failure, in terms of postoperative cognitive function, in terms of number of RBC transfusions and transfusion thresholds, and then also in strokes and neurological outcomes and length of stay with mechanical ventilation and so on. I will be the first to admit that I do believe that larger trials need to be done in this space with more patient-centric outcomes. Let me talk a little bit more about cerebral desaturation, and I've talked about some of these concepts of the ICU patient, hemodynamic instability, shock, blood loss, RV failure, and suboptimal oxygenation and ventilation. How do all of these fit in? Now, the studies I'm going to show will tell you that up to 30 to 40% of our cardiac surgical patients do have cerebral desaturation. Patients who do have cerebral desaturation, furthermore, have lots and lots of events and lots of cumulative time spent under a cerebral desaturation threshold. The next obvious question is, does it matter clinically? So yes, my patient has cerebral desaturation. We don't pick it up, but does it matter clinically? Before I get to that, there is studies such as this one right here where they compared blinded versus unblinded cerebral oxygenation monitoring. In the monitoring and intervention arm, there was nearly a 50% reduction in time spent in a desaturated state, okay? Again, you are going to think and ask me, is there a clinical correlation to all of this? I will tell you that studies that have been done are small randomized trials that have shown that there is a clinical correlation. However, we need to do larger pragmatic trials where we can build on evidence like this. If there is indeed a 50% reduction we can achieve, how do these patients do that have a 50% reduction compared to those that continue to desaturate? I'm going to switch gears a little bit and go towards ECMO and go specifically towards the applications of NIRS in ECMO patients. And the two things I'm going to talk about are the north-south syndrome and monitoring of distal limb perfusion. So what is the north-south syndrome? This is a very simple infographic. I think most of you in the audience know. You put your patient on VA ECMO. Patient has almost little to no cardiac function to start. But as the cardiac function starts recovering, there is essentially a competition from the relatively deoxygenated blood that the heart is pumping to the ECMO flow that is oxygenated, and then across the left and right side of circulation that reflects. And if you do have a pulse oximeter on the right side, you'll see that the right-sided pulse oximeter will read lower than the left-sided pulse oximeter. It's a common situation. It's a dangerous situation. It does go under-recognized and not detected in time. If we did have bilateral NIRS monitors, it would be easy to detect, easy to pick up early, and then there is obviously ways to salvage the situation as well. I'm not going into those salvage methodology right now, but happy to take those questions afterwards. Limb ischemia is also a really, really important complication of patients on extracorporeal circuits. There is when we talk about limb ischemia, we want to talk about detection, prevention, and management. Yes, when we talk about detection, this is where there is a somatic application of near-infrared spectroscopy. Yes, there is physical examination and biochemical markers that are really important too. When we talk about prevention, things like putting a distal perfusion catheter, a lot of sites will be really, really proactive in putting in a distal perfusion catheter. And then in the management part of things, changing ECMO configuration, early revascularization helps. Obviously, you get to fasciotomy and amputation. That is not a good outcome. So how does this happen, and where does NIRS come in? So typically, femoral vessels, large size arterial cannula, patient with vascular disease, which is really, really common, or patient on multiple vasopressors. You put these cannulas in, there is compromised downstream circulation and flow, and typically you'll see that your patient has a limb that is cold. Now, if you had somatic NIRS on these patients, then data does suggest that less than 50% to 15% difference between the two limbs was nearly 100% sensitive and specific for the detection of clinical signs of ischemia. So this was a study that compared clinical examination compared to physical examination in these small 25 patient subset. I will tell you that this is one application that we commonly use in our intensive care unit. We found it to be extremely beneficial. Obviously, we use physical exam. We're going to do Dopplerable pulses, but we do add this, and it has helped us a lot of times salvaging our patients. The other interesting and sort of the evolution of use in this area is limb compartment syndrome. And again, the data is still in evolution here. This is a meta-analysis here, 38 trials across about 2,000 patients. And they did conclude that there was sufficient evidence to the use of NIRS in the assessment of chronic compartment syndrome, and also as a tool for detection of free flap failure. And I'll talk a little bit more about why and what we need to do. And I really feel that this is an important slide because, yes, we are using NIRS and we're using it every day, but there's things we need clarity on and things that we continue to evolve and develop as clinician scientists. Should NIRS somatic sensors be used to detect acute limb ischemia? I think for me that answer is pretty clear, and the answer is yes. What tissue oxygenation value should be used as a cutoff, and should the magnitude of change in tissue oxygenation be used in diagnosing limb ischemia? I personally, I look at my patient's baseline and I look at the delta and I look at the patient, what is happening to the patient when I make those determinations. So I would not like to specifically assign values here. Is NIRS the ideal clinical tissue oxygenation monitor? What other monitors could be used? And should a distal perfusion catheter be placed prophylactically or if acute limb ischemia develops? At our center, we don't place distal perfusion catheters prophylactically as a routine. But yes, we do respond to NIRS values, and then we do have distal perfusion catheters placed if there is a situation that demands it. There is obviously unanswered questions here, and I think those are areas we still need to further work on, build more evidence. I'll also pose some very interesting areas, and as I come to the end of this presentation, I'll talk to you about some interesting areas of creative utilization of NIRS. One was this study that I came across where they used cerebral oxygenation monitoring during cardiopulmonary resuscitation, ECPR, and they found that patients who regained consciousness had higher mean cerebral oxygenation values, so both mean and median cerebral oxygenation values in patients who regained consciousness were higher than those that had no return or poor return of neurological functions. That's a really interesting use. I will say that it's difficult to translate that into every single patient that will be having cardiopulmonary resuscitation, but it's an interesting piece of data. I will now share with you some clinical examples, some published and some unpublished and from personal experience. Here is one that is published where we've had a north-south syndrome here. So the two shades of the RSO2 are the left and the right side. As you can see, they've both started at the usual 65. And as the innate cardiac output kicks in, the right-sided SO2 starts suffering, and there is a separation. Both go down, but the right goes down more than the left, till the point that the users have adjusted mechanical ventilation and brought in the lungs into the circuit, and then have improved cerebral oxygenation, and both curves have nearly gone back to their baseline after these adjustments. So this is typical, the typical scenario with north-south syndrome. This was really interesting, and I thought that that this is fairly creative. So this is right leg in dark blue, left leg in yellow, and then the light blue is a cerebral NIRS. What is happening here is that at some stage after cardiac surgery, everything looks okay. Then there's a tamponade, and because of the tamponade, cerebral the venous side of the cerebral oxygenation has been impaired in terms of oxygen extraction. So the cerebral oxygenation has paradoxically gone up, and that has prompted the users to further investigate this. And if you look at the case report, they obviously did a TE, and then they went ahead and performed a retrothoracotomy and rescued this patient. So fairly interesting example right here. This is the example with distal limb ischemia that I talked about. Again, left and right to start, monitoring is initiated, the right side drops, and then you have an intervention, you place a distal perfusion cannula. Interestingly, there's been an uptick on the right side and a further decline in the right-sided values. They figured that they had vascular injury while placing the right-sided distal perfusion cannula, and they've gone in and repaired this and restored NIRS values. So all interesting, but this gets really interesting. So this is something that happened with me about 2 weeks ago, and I thought it was perfect timing because I was on ICU service, and this is a patient that was transferred to us from one of our community hospitals. We're all having the respiratory sort of mini pandemic with everyone getting community-acquired pneumonias. Community-acquired pneumonia came to us for consideration for ECMO. Patient had a fairly high BMI in the 50s, late 40s, about 50. At this stage, you see the patient's intubated. This is the baseline chest X-ray here. So we cannulate the patient for ECMO. So this is actually, let me just go back and tell you the story. So we cannulate the patient for ECMO, and this cannulation happens at night. And the story is interesting because, you know, the family talks to me at night. I'm on night shift in the ICU, and the family says, you know, they're kind of, you know, overwhelmed. And I'm telling you the story after permission from family. I will also say that because, you know, I talk to the family if I can share the story as a teaching point. So the family talks to me and says, you know, we're really scared. You know, this has happened. This has evolved really quickly. You've put this patient on ECMO. This is a huge circuit. We see all the blood flowing in and out. Is everything going to be okay? Do you ever have catastrophes with this ECMO circuit? It seems really complicated. And I look at them and I say, look, there's one-on-one nursing. We do this every day. We've done this for years together. These devices are being used all over the world. Don't worry about it. Go home. Everything will be okay. I come back the next day, and you know, there's been an issue. So the issue is as follows. And can you identify the issue? You see this. What is this? Anyone? So if I tell you that we cannulated the patient with a right IJ, right femoral approach, a VV ECMO cannulation, drainage from the right femoral and back to the patient from the right IJ, then I show you this X-ray. What are you guys thinking? Anyone's thinking anything is abnormal? Or should I ask my fellows? Okay. So now I've highlighted it for you. That does look like a cannula that's almost out, right? And that does look like a hematoma in the neck and the mediastinum. And if you look at the other side, this looks way worse, right? So what happened is, you know, there was a mechanical event where the patient was turned over for a chest X-ray, and the cannula got displaced. There was a cardiac arrest. The patient was emergently resuscitated, and a left femoral venous cannula was emergently and efficiently placed. Kudos to the team that jumped on this within minutes and got the patient recannulated. So the patient then got bilateral femoral cannulas just as a rescue procedure so we can maintain circulation. Then we formally went back to see what could be done, and an effort was made to place the right-sided displaced cannula back into the blood vessel. Did not succeed, so you see the guide wire here coming down the left side. So finally, a left-sided, left IJ cannula was placed as a return cannula, and both the femoral cannulas were retained as a drainage cannula. This is the left IJ cannula coming in right here. Now, how do you think all of this connects with NIRS? Any ideas? You can speak up. I know you want to say something.
It would have been tipped off maybe. It would have been tipped off sooner if this had migrated out of position before.
Okay. That's one thought. Yes, sir. Okay. So, I like the way you're thinking. I like the way you're thinking too. When these catastrophic events happen, they happen really quickly, right? This comes out, there's a cardiac arrest in like 30 seconds, right? There's like 4 liters per minute of blood flow going into the neck instead of going inside, right? Where we use the NIRS here is that we had a significant hematoma in the neck, even after repositioning the cannulas, right? We were worried about carotid compromise. So we got the NIRS back on this patient, and then we monitored left and right-sided NIRS just to make sure that there was not a impending, expanding hematoma and right-sided carotid compromise. That's how we used the NIRS. This is a follow-up X-ray of that patient in the days to come. I'm happy to tell you that I spoke with this family last week before I came here, just to make sure they were all kosher with this, and the patient's doing well, extubated and on his way home. So great job by this team, and then great utilization, very creative utilization of NIRS, and very timely because it was before my presentation. I was on service, so I thought I'd share this with you guys. Anyway, so coming to the end of this, we've talked about NIRS across the care continuum. As I said, we can start NIRS in the preoperative area. We can look at it in the intraoperative period, and then in the postoperative space. There is unanswered questions. There is areas we need to work on. But I will still say that the technology is non-invasive, easy to use, gets you an extra data point, and allows you to monitor the local oxygenation at the level of the brain more effectively. These are 4 bullet points of a summary. I think I've already summarized what I've said. I want to leave time for questions and discussion. Thank you. Thank you.